So, good afternoon, everyone. I'm really excited to be here today, to have the opportunity to be here for the last step of MegaMind 2026. It's a big day for me, and I hope you will enjoy my presentation. Today, I'm going to talk to you about the implantologist paradox and how mastering implantology brings you from the master of one to the master of many. So I'm Dr. Adel Hamdani, I'm from Paris, and I'm an oral surgeon specialized in implantology. And I like to see myself like a half surgeon and half artist, and I think we are all artists here. We are all performing art every day, like we saw during all this day. And we are artists in a digital era, and we saw it today. I think almost all of the presentation were talking about the digital flow, and it's tools that we learn to use, we learn to master. From the segmentation, matching, to the setups, implant planning, all of this brings us to the guided surgery, which is a treatment we can bring to our patients the best solution. But to achieve this, we need some tools. Those tools are the planning software, the surgical guide, and also the full guided surgical kit. And what does it bring to the table? It brings precision, predictability, but also it reduces the surgical time, which is a gift that we can give to our patients. Because tomorrow, if I need a surgery, I want it to be very short, especially if I'm in local anesthesia. So, like I said, during all this day, we saw the tools we used to propose to our patient every day. This is our daily practice today. If somebody is saying guided surgery is the future, I'm not agree with this person, it's the present. We are mastering this now. And now that we are mastering precision, what else can we do with it? What can we do with it? We can choose to still dreaming. Are we still dreaming? Because the dream, it's comfortable, it's simple, it's easy, it's familiar. We have a missing tooth, we place an implant. That's easy to think like that. But unfortunately, the reality is really different. We have a missing tooth, we have a specific patient, and we have to think what is the best option for this patient. It's more precise, it expands our practice, and it's centered on the patient. So I want to introduce you my patient. She's a young woman from 21 years old, perfectly healthy, and she's coming for something very basics. We can see this kind of patient every day, every week. She needs an extraction of tooth 5.5, which remain on the denture because she has an agenesis of the tooth 1.5, and she wants a solution. Some years ago, I would have chosen the dream. Let's go for an implant. Let's go immediate with maybe full guided surgery. It's easy. We know how to do it. It's effective. But is it the best solution? That's the obvious answer. But is it the best solution for our patient? Like I said, she's 21 years old. So she's very young. If we check the statistics from the life expectancy in France, because she's French, beside accident, she has to live like 65 years or 65 years more. So it's a lot. Will your implant last 65 years? Personally, mine, I'm not really sure. and I'm really meticulous with my implant cases. But why? Because she's young. If we are looking about the science base, we know that her craniofacial growth may continue until she's 25. And also we have alveolo-dental change, and we know it, the implant will not follow. So what does it mean? It means we have to do prosthodontic reintervention. Maybe we will have to remove the implant, do another graft, replace the implant. All of this, when we don't have choice, and we have to deal with the complication, it's okay. But when we have to take in charge the patient at the beginning, we have to think further. Finally, there is periimplantitis, which is a big complication. It's a nightmare like implantologist. And it touched like 25% of the patients. And for patients who has periodontal disease history, it's even more. She's 21 years old. So I go back to my tools. I go back to my planing software. I go back to all these tools which are limited only by our imagination. I do my patient examination, and I propose her to go for an autotransplantation. Full guided, of course, because she still has her wisdom teeth. So, same tools, different use. We know how to use these tools. We can access to other surgeries. Autotransplantation. What is autotransplantation? Maybe some of you already perform it. Maybe some of you hear about it. Personally, when I was a student, never heard about autotransplantation. When I did my residency, never heard about autotransplantation. When I did my postgraduate in implantology, never heard about autotransplantation. But we have many publications about it. We can place a tooth inside its own socket, what it is called intentional reimplantation. We can place it to the socket to another tooth, just like in my patient case. And we can create a new socket for the tooth if the tooth is already missing. But maybe you will tell me, okay, autotransplantation, it's a pretty cool idea, but implant lasts longer. So we have to go to the evidence-based. And today, we don't have only a systematic review with meta-analysis about autotransplantation. We have umbrella review, which means we have a lot of systematic reviews, like 1 or 2 every year since 2023. And the 10-year survival rate is up to 95%. The survival rate at 10 years for implants is around 96%, so no difference. An example with this case, where the patient needed the extraction of tooth 3.6, extraction done, placement of tooth 2.8, and the follow-up at 6 years. Perfectly healthy, functional tooth, vital pulp. I want to insist on the fact that the patient is 21 years old. I said it a lot, but it's really important because we know that more than 95% of pulp a transplantation of open apex tooth lead to a pulp revascularization. So we will keep a vital tooth. So it changed everything. I go back to the digital workflow. We know how to use it. We use it every day. It's not so different if we go to another technique. We're going for matching and segmentation. Then we will do the transplant position planing, osteotomy planing, autotransplantation osteotomy guide design, and then we can, if we want to be really precise, we can do a repositioning guide. So go back to the situation of my patients with this tooth 5.5. So we will start with the extraction of the tooth, which is pretty easy. And then we will use the osteotomy guide. And the design is kind of funny, because most of the time when I show this kind of guide to my colleagues who are doing implantology too, they're asking me why there is 3 sleeves on your implants guide. So I like to think about it like an alien guide. Extraction of the tooth and placement of the osteotomy guide. This osteotomy guide is based on the principle of the implantology guide, and it helps to have something predictable, and it can lead to democratize the autotransplantation. Unfortunately, we don't have enough publication about the apport of the osteotomy guide for autotransplantation, but definitely it helps to standardize the technique. When you use it, it's kind of the same when you are placing implants full guided. We just use your full guided surgical kit and you do your osteotomy. Then we will use what we are calling transplant replica. The transplant replica is based on the segmentation of the tooth we are going to transplant, and we are going to 3D print it. We can try it, place it, we can do as many try-in that you want without using the transplant, without traumatize the transplant. It will reduce the extra-alveolar time of the transplant, and it helps to be less traumatizing on the alveolar bone. As you can see today, with the AI tools of segmentation, we can have something very similar to the transplant based on the dimensions. Then we replace the transplant and we can use this repositioning guide. The repositioning guide is like the details on the protocol, but it can help to be really precise. For example, if you do a transplantation in general anesthesia, you're not able to check the occlusion. So it will help you to place the transplant under the occlusion and to have exactly the placement you plan on your planning software. On this case, I had an idea and I planned it to transform the repositioning guide to a splint. So I just have to place my transplant with the repositioning guide, do my bonding protocol, and then I cut it, and it's over. The post-operative situation, we have the post-operative X-ray, and we're going for the follow-up. At 6 months, as we can see, we have total bone healing, closure of apex, positive cold test, physiological depth probing. At 2 years follow-up, as we can see, the bone defect is totally regenerated. No bone graft material. And I did the surface matching between 2 years follow-up, the CBCT of the 2 years follow-up, and the planing, and we have a similar position, very precise position of the transplant. Situation at 2 years follow-up, positive cold test, physiological depth probing. So what I want to say on my presentation today is not you have to choose between transplantation and implant. You have to do both because you have the tools and you have the tools and the knowledge to perform it. So choose both. In some situations, the implant is better. In others, the transplant will be better. and go beyond. Don't stop thinking only about implants. Implants is a good solution, but we have tools to go beyond that and do more. So implantology is not the ceiling, it's the launchpad. So I hope you will come with me and we'll go to the store. Thank you.